and I was actually starting in the nurse practitioner program in 1974. It was one semester.
And were you all training one-on-one with a physician?
Yes. Yeah.
Okay. And then once you finished the program, what was your first job as a nurse practitioner, and what were your main duties? What did you do?
Well, at first I was hired by my preceptorship, Dr. Hansen. And it just sort of fell in order. He had a partner, a younger doctor, who changed and went back to the University of Iowa's medical school and was an instructor. And so Dr. Hansen was rather alone. And I always assumed that he would get another partner. But he stayed. And one time he called the office, kind of a sit-down time. And he says, I'm not going to get a partner. We'll just work together.
During those early years, were you able to prescribe medications? Was that?
Oh, no.
No.
That was never an offering. Matter of fact, we didn't really review that within my training.
So that wasn't part of that early phase?
No, but eventually through the different programs, it became quite evident that we needed to have a handle on that. We had our offices in their hospital, and we would run clinics. I don't remember how often, but they would be clinics, and with the appointments and everything for children that were at risk of developmental delays. And we followed them. Usually it was from the hospital, understanding that the child had a difficult birth or was a multiple birth, premature, and we would follow them for at least 3 years.
How were you received by doctors and nurses and patients, for that matter, in the early development of the profession? Like, how did they relate to you?
Well, when I was trying to find my preceptorship, I interviewed in Waverly, 3 doctors. And one of them says, oh no, we have way too many women in our office already. We don't need anyone. And the other one says, oh no, we aren't hiring. We're established here, and we don't need another office examining or anything like that. So it wasn't something that they really felt contributed. No. We would have many times children that had very, very severe chronic developmental problems, orthopedic or spina bifida, cerebral palsy. And the focus was then to make sure that the community was giving the support. And that was opening a new area for nurses to do within home health and all. So you can kind of sense that everything was kind of getting a different approach for health and families. It was always one way and then another. It wasn't very exacting. They didn't have anything that they were following. But I felt that the University of Iowa was pretty much a leader once they got started with their program, a very strong program. And they had nurse practitioners from then on with developing and becoming certified. Yeah.
It's been an amazing development, just looking at where the nurse practitioner profession is today, where a lot of American children have a pediatric nurse practitioner as their primary provider, right? I have colleagues here who run clinics, and they are functioning alongside their doctor colleagues.
Yeah. Yes, you're right. Yeah. I know now I'm in this retirement center, and I have friends. I meet often with retired nurses, and we review history and laugh and talk about it and things like that. But anyway, most of them say, well, we all have this health problems. I'm pretty good, but anyway. And they say, I never see my doctor. I am always with my nurse practitioner or my PA. I haven't seen my doctor. I don't know, maybe he's in another office. I don't see him.
Why did you get involved in the California Association for Nurse Practitioners? And what do you see as the main purposes of having such a professional organizations dedicated to nurse practitioner practice?
I was very fortunate during my training to um, get from the very start how important that professional advocacy role is, and to understand that as a nurse practitioner, I was entering a space and a place as a professional. In other words, not as an employee so much anymore, no matter, how or where my paycheck was to come from, but as someone who was able to determine and make decisions about how I practiced and where I practiced, including all of the values around that. My values about people and caring for people and serving others. And a huge part of that then is that care for the profession. I understood very early on that it was only in connecting with other nurse practitioners, to learn from them, to hear about their practices, to share my struggles, and get encouragement, that that was the only way that I would be able to learn and grow, and actually thrive in my profession. It doesn't matter how much training you have. It doesn't matter what skills you have. If your legal system doesn't license you to perform in that way, it doesn't matter. So that's why it's always been very important for me to be a part of making sure that those legislative changes happened, in order to enable us to practice to to the top of our license. We're still getting there, but man, we've gotten much farther than I dreamed that we could at this point.
In your experience with CNP, what strategies and talking points have been successful in gaining political support to strengthen the NP profession in the state? In other words, what has helped politicians, the public, healthcare organizations see the value and the need for strong NP practice? How did we get here?
Well, it's been a long, hard road. I would say that the attempt to get any form of independent practice has been one that has been a goal from the beginning of the formation of our professional organization. What really enabled the current legislation to take hold and then become successful was just the reality of the healthcare situation that we find ourselves in, where we have an overabundance of patients needing care and a true and increasingly dire shortage of physicians to take care of those patients. And we're definitely seeing the terrible ramifications of that situation. At the same time, because nurse practitioners have been in practice for over 50 years now, then our profession has grown over those years. We have many studies that have shown safety and efficacy of our practice and our ability to meet those gaps in healthcare. And so the current champion, Assembly Member Jim Wood, he comes from a rural district who saw firsthand in his district the dire consequences of the lack of primary care, and particularly primary care physicians, and how people were really going without vital health care, and how the nurse practitioners who were working in his district were doing a wonderful job. So that healthcare need, combined with the data that we have, a very strong set of consistent data showing safety and efficacy and quality, those two things then finally made it possible. And then the third thing that happened in the middle of that was the pandemic. So with the pandemic, all of those simmering health problems really came to the forefront and became reality to anyone who had eyes to see, and certainly our politicians saw firsthand the need. And those who asked even the first questions really saw how nurse practitioners were a huge part of the professionals who stepped up to take care of people suffering in the pandemic.
What are you most proud of from your years of leadership in the California Association for Nurse Practitioners, especially your recent presidency?
I think the thing that I'm most proud of is how I witnessed firsthand how my nurse practitioner colleagues just stepped up so spectacularly to meet the dire needs that presented themselves during the pandemic. And I would say that your practice in particular is probably one of the main examples when I think about those days. So being able to be in a position where I could see the large picture, see like the overview, in addition to being able to be on the boots or on the ground during that time of such fear and uncertainty. I am so proud of how my colleagues, how I was able to witness nurse practitioners really step up and just show everyone the truth of what we've been saying all along, that nurse practitioners provide very high quality, safe, compassionate care. And we really do need to make sure that we're able to provide that care without restriction.
At that point, I always had this dream of running a clinic by nurses rather than working for doctors, because in the 80s that I was working, definitely the doctors were the ones running the medical units and the psychiatric units. When I first started being a clinical nurse specialist, which is what I graduated to, we weren't doing the meds, except we would write a script, but then the doctor had to sign it. So we didn't really have that as part of our practice. And really what I was doing was evaluations and treatment and group therapy.
When did that change, venturing into prescribing medication on your own? And
So
what was
probably, yeah, in around the 90s, somewhere in the 90s, the law changed that we could have prescriptive authority. And once that happened, it really shifted my practice into primarily being medication management, but I maintained an interest in doing psychotherapy as well. So I always had done that in my private practice. So I did a lot of psychotherapy, individual and couples and group, along with medication management. We had a psychiatrist that I had worked with at the VA, and he basically did group supervision with a couple of other nurse practitioners besides me. And so we would discuss cases with him and with each other. It was I thought, very good to be able to do that.
Great. And then when did you first have your own total independent practice where you were prescribing, et cetera?
I think in the early 2000s was when I really started doing, it would have been, I'm trying to think now. It would have been probably maybe 2010 that I would have actually not needed a psychiatrist. And I think we ended that. We tried to continue, though, the collaborative discussions, because those were valuable to us in terms of our own supervision of our practice.
Hey, Marianne, I wanted to add on one more question about your practice areas. I heard that you did some work together with a psychiatrist supporting nursing homes, which is a potential big area for nurse practitioners in Norway. Can you tell me a bit about that?
So I was working with a psychiatrist at Griffin Hospital in the outpatient clinic. And we contracted with all the area nursing homes to do assessments and education to help them deal with the sudden influx of a lot of psychiatric patients to their system, which they weren't prepared to manage well. And patients were either getting over medicated or they were simply getting re-hospitalized constantly. And so through our work, we really did help them to learn how to manage these patients and decrease the sort of rotating door at the hospital, which I thought was very helpful.
This was during the time after a lot of psychiatric institutions were closed down. So
Right, it was post deinstitutionalization. I mean, so, you know, that had happened quite a few years before, but people were being shunted then to hospitals, I mean, to nursing homes and to jails and other places because they weren't properly treated out in the community. There was, you know, small community health centers, but they were overwhelmed and didn't provide the things that they really needed, which was housing and jobs and structure, which they had probably gotten in the institution, but then they went out into the community and didn't have that. But then they were then, because they needed housing and they needed all these other things, they were just shunted into nursing homes and jails. So I felt like our work at the nursing home was really important in terms of providing some of what they needed from the nursing home without having to go back into the hospital.
My experience with nurse practitioners has been very positive, and in fact, I'm a strong supporter of nurse practitioners and physician assistants working alongside with physicians in any setting because of what Lars has done and working alongside with him in these last couple of years.
How has the integration of nurse practitioners been perceived in general by our hospitalist physician group, and what factors or strategies do you think were important during the integration process?
I think, in all honesty, there was I don't want to say a stigma, but there was a apprehension in working with nurse practitioners, just because, again, we weren't very familiar with working alongside nurse practitioners. And I would say that COVID and the need for a clinical engine actually accelerated that relationship. And so instead of actually choosing to work with nurse practitioners, it was actually a need. So I would say in that aspect, we didn't have a choice, but it was actually a good thing because as we worked alongside with nurse practitioners throughout COVID, it became more and more apparent that we were able to work with nurse practitioners, and we became more and more comfortable. There were some growing pains, I think, just because of the level of trust. It was never that we didn't think that nurse practitioners could do the work, but it was how we were going to interact with them, what responsibilities were going to eventually pan out in terms of the relationship. And I think once we started hashing out kind of roles and responsibilities, it started becoming more apparent, more clear what our roles would be. And in fact, actually, it's morphed over time. Now they are an integral part of our group instead of just being kind of just there to help. And they work with us during admissions in the hospitals and along with discharge. So there's almost actually no difference in terms of what a physician does and a nurse practitioner does. It actually helps expand our reach in the hospital and taking care of patients. I see them as an equal provider with the physician. Without them actually, especially because I do a lot of admitting shifts from the ER into the hospital, and I work mainly at night. And so we usually have 1 to 2 nurse practitioners working alongside us at night. And we are all a team. And the way that I interact with nurse practitioners is they are right alongside me as my colleague. because without them, I wouldn't be able to do my work, and without me, they wouldn't be able to do their work. So we work together hand in hand, and our responsibilities are exactly the same.
I'll quote one of my colleagues who also leads another University of California campus. If you're not at the table, you're on the menu. So we really do need to be at the table and having discussions regarding our own practice and also how we complement the team, what we bring to the table that I think really differentiates us from other providers. When we discharge a patient home, we're making sure that everything is ready to go and that that patient is going to be safe at home and that they have everything that they need. I think that comes from our nursing background and really heralds back to when we ourselves were helping that patient to transition back to the community. And so it's really important when we're looking at how we're structuring care that we're at the table and having those discussions.
How have you been able to establish that leadership structure here at UC Davis? How were you able to get heard and build the alliances that were necessary?
So I used the information that we had, which was that we were more successful than anyone else at getting patients home safely and in a timely fashion, and that we were a cost-effective part of the workforce here at UC Davis, and that could be replicated across numerous services. And that's really how we began that structure of including advanced practice team members at the table when we're looking at workforce planning. I believe that any time we're trying to make a change, we need to understand the obstacles and the barriers that are in the way of that change going forward, and that it takes time for people to adjust to change. And as long as you approach it from the standpoint of partnership rather than forcing a change, you're more likely to be heard. It's also important to understand who are the strategic partners in that. Who do we need to make friends with before we start any change process? Who are our champions potentially that are going to be helpful in moving the change forward and getting yourself into a new practice area? And also, on the other hand, who are the people who are going to oppose that change, and what are their concerns, and how can we address those on the front end so that we're successful in integrating into the new practice? I think it's not always about, not every country has a revenue generating model. That may not be important, but what might be important is cost avoidance, is how we as clinicians can help to avoid rehospitalization. So there's a range of ways to look at the value that advanced practice providers bring. Also, patient experience. I think we really care about the patient having a good experience during their hospital and ambulatory visits. And so I think that also adds value. And so when I'm looking at our workforce, I really look at it from a broad perspective and how and where we might grow. In the US, we actually are very concerned about looking at, are we meeting national benchmarks for access to care? So it should take 4 or 5 days to get in to see an oncologist if you have a new diagnosis of cancer. If we're taking 16 days, we need to look at how can we shift a workforce of advanced practice providers to help those patients get into the clinic sooner and get their diagnostic workup and everything managed so that we can effectively manage those patients. And that's not about revenue generation. That is about patient experience and also about access to care, which is important as well. I think that when we use every provider to top of scope, number one, all of our workforce has a better experience working because they all feel valued and they all feel that they're able to do difficult, complex cases that actually highlight the skill that they have. And when we use them in a way that doesn't make sense, for example, having an advanced practice provider who can actually see patients, call back people to tell them their lab results, or walk a patient from the front of the office to the back of the office to room them, that's actually underutilization of that provider, and it's not efficient. And so our goal is to actually translate and reevaluate our workforce to sort of right-size roles so that we have every provider doing work that really speaks to the amount of skill and training they have.
Thank you for inviting me to speak today on our fellowship programs. We are very proud at UC Davis Health of our advanced practice fellowship programs. We currently have a program that has 8 tracks in specialty care that's targeted at taking new graduate nurse practitioners and physician assistants. And within that first 18 months after graduation, having them begin a fellowship program that really works on developing their skills as they transition to practice in specialty care. Our program is specifically targeted at specialty care, specifically that these providers typically would not find initial employment right out of school in these specific areas. So we've created programs, curriculum, didactic education, really to support a new graduate as they come into that specialty service. Right now, we currently have burn surgery, oncology, orthopedics, neurology, neurosurgery, inpatient glycemic team, endocrinology, radiology, trauma surgery. We have 8 specialty programs that are individualized curriculum that we've developed. We use an advisory board that oversees our fellowship programs and the development of each track. So it's a collaborative opportunity for our leadership throughout the health system to develop these programs. So we are seeing national trends in residencies and fellowships, interchangeable terms based on different locations and hospital staffing. We chose to use fellowship for our program here based on residents in an academic setting are not finished with their training yet or licensed, and our fellows are licensed and privileged as independent providers here. So we chose to use the term fellowship for our program. You will see national trends of fellowships popping up across our nation, specifically lots of different various areas that can be specialty care. They can also be in primary care. A couple of things you may notice, there's differences in programs based on some programs will have one content, like one area that they focus in and they have multiple learners. And others are similar to our program where we have various different programs in different specialty areas with one or a few learners that are, or a few fellows that are in each of those programs. So interestingly enough, some of the things we developed for our fellowship program and to support those fellows that were in our program have now been expanded throughout our whole advanced practice community. Mentorship is one of those areas. We started out with having a mentorship program, partnering our current fellowship fellow with a prior graduate to mentor them through that 1-year transition. That program showed value and a large amount of success. We have now created a structure that has implemented advanced practice mentoring throughout our health system, looking at all of our providers in the inpatient as well as ambulatory settings and how we can find ways to partner and mentor. This is in collaboration as well with the School of Nursing and different leaders in education there.